are excited to also partner with many folks on the call today and have you be able to hear from many of our local experts here in Michigan. So our partners for today are the Opioid Advisory Commission, the Michigan Association of Recovery Community Organizations, the Michigan Overdose Prevention Coalition, and the Michigan Department of Health and Human Services. So excited to have our panelists from those agencies and some of today's session moderated by Scott DeZerka as well. And so we will jump into a bit of today's agenda. This session is really intended to provide information on how best to meaningfully engage with individuals with lived experience. And so we'll be covering a bit about defining what lived experience is and means, the importance of representation, specifically related to opioid settlement funds, but really expanding into all of the work in this space. And then we'll have our panel discussion with our speakers. We have Tara King, Patrick Patterson, Andrew Coleman, Brandon Poole, and the panel will be moderated by Scott DeZerka. And then we'll provide some additional resources and a brief feedback survey at the end of today's session for you all to fill out. Today's session is being recorded and will be provided on the Michigan Association of Counties website and some of the partner agencies' websites after this session. And we do have everyone muted for today's call, so please use the chat feature if you have any questions, and we really want to hear from you throughout today's session. So I will hand this over to Scott.
Great. Thank you, Amy, and good afternoon, everyone. Great to see so many familiar faces for me. I chuckle. This is an anniversary year for me. It was 30 years ago since I started at the Association of Counties. So it's great, but it's also overwhelming to see some people are still in those same roles after 30 years. So kudos to all of you who continue your service within county government. As Amy said, today we're going to be talking a little bit about voices of lived experience. And we thought it would be helpful just from a context basis to frame this conversation using a personal story of an individual with lived experience. So if you could just enjoy and understand this video that we're about to share, we'd appreciate it to kick things off.
She was a redhead, gregarious, outgoing, adventurous, and smart. She did very well in school, graduated with honors, a merit scholar. She had immense amount of pain from early childhood. I don't really know where it all came from. Antidepressants numbed her, but drugs numbed her more. And so we saw a real personality shift. I unfortunately lost my daughter to a heroin overdose in 2012, and she was only 21 years old. I mean, I'll never forget the day that she died, and she just finished a semester of college. And that was the first time she'd gone back in a while. And she called to tell me that she had these really great classes, and she needs some books. And even though I knew you can't give them money, you can't give them gift cards, it's just gonna go for drug use. She says, I just need $60. Instead of going, great, let me order those books for you, I transferred money to her bank account, and she was probably dead in an hour. I said goodbye to my daughter in a body bag.
I think that the narrative that has been built in this country about what a substance user is completely false. A lot of people think that, a drug user is like a bottom of the barrel person, no education. And the bottom line is drug users are also human. They don't look a certain way. People use substances everywhere, in every community. I'm currently pursuing a master's in public health at the University of Michigan through the Department of Health Management and Policy. I identify as a recovered addict, and I have really been able to use my experiences from being a substance user to have an impact on recovery and what that means, and I try to use those experiences as much as I can to help others. It's really been embedded in everything that I do. Policy is never going to be perfect, but there's so much room for improvement. And just from some of the research I've done and the community groups that I'm involved in, we know what works and what doesn't work. And unfortunately, we're still using policies that are not effective.
So much of what we're taught about drug use and substance use disorder is harmful. Drugs are bad and bad people do drugs perspective doesn't help to understand that people are just looking for a way to cope. And we have to look at a lot of the systems that we've had historically have been about punishment. And punishment typically doesn't change behavior. Accountability is a very different perspective. And accountability can help somebody, especially early on in their recovery, because they want to change, they just don't know how. They've lived in their substance use and addiction for so long, they know how to live that life. They know what to expect from it. So when we can have people in their life that to help them be accountable, whether it's taking their medication to help them with their recovery, whether it's just being able to out themselves to their struggle that they're going through, or the feelings or the emotions that they're going through, that goes so much further than trying to incarcerate it away. I know people that went to prison that didn't use drugs during prison and got out and they went right back to what they knew because we don't have a system of support.
I've lost many people to overdoses whom I've been close to. One in particular, his drug use led him to engage in just minor criminal activity to support his habit. And ultimately, he ended up being sentenced to prison for 3 years. When he was released without any Narcan, without any really guided resources to the community, without housing, and was able to find a job, but the core of what the issue really was, which was his substance use, was never fully addressed. He never had an opportunity to work on that. And within 6 months, he overdosed and died. One of the main things we need to shift into in policy is focusing on harm reduction efforts. Obviously, the criminalization of people who use substances is not the solution. We still have overdose rates that have skyrocketed over the years. And I think that people who use substances should be treated just like anybody else who suffers from an illness. If you look at what we do know with people who suffer from cancer or diabetes, they're treated in the healthcare system. They're treated as human beings. They're not given a ticket and sentenced to jail. So I think shifting into harm reduction to help save lives and additionally incorporating more treatment resources is a key thing that we should focus on.
So syringe programs were something I had to kind of grasp around. Now it's it just makes so much sense. Not giving somebody access to syringes isn't going to stop their use. So let's at least try to keep them healthy. But what's more important is that it's about non-judgment. It's about compassion. And syringe programs understand that people are going to use drugs. Let's not fill them with more shame. Being able to be a person who is not a person with lived experience, to accept it, is really a big part of what we need to change. You're not just giving syringes to somebody using. No, you're helping to keep them alive. We stay connected with a lot of our participants in ways to check in on them. How are they doing? What's going on? What do they need? Connecting them to resources and services and testing and treatment. And so it's about meeting people truly where they're at.
So I always kind of take it back to things we already know about, like seatbelts. That is a harm reduction tactic. Everybody is supposed to wear a seatbelt when you're driving a vehicle to, be safer in an accident. I think it's the same thing with giving somebody Narcan or allowing them to have access to syringe service programs. Those are things that can help people who are actively using substances use safely. And I know there are beliefs that that's encouraging drug use or going to increase drug use. There's no data to support that.
I think one of the most important pieces that I really want everyone to understand is that they're a human being first. Everybody comes here just wanting to be cared about and wanting to be loved. When we stigmatize their coping mechanism, we're doing harm. And to stop and take a beat, what have they been through? What can I do to support them? Because every one of those people have a story. They have something that they've been through. And then when they get mistreated because the society doesn't like to see them, and doesn't understand them, we're doing harm. And yet there's a great population of people who we don't see that struggle with substance use disorder. Addiction knows no boundaries. And as long as we don't teach healthy, positive coping mechanisms, drugs and alcohol will always be there. So we have to change as a society.
Thank you for that. I think Nancy's comments at the end and certainly sprinkled throughout really capture the conversation we're having today. We're talking about people, we're talking about individuals, we're talking about their stories and how we can show some compassion to individuals with these experiences. So we thought today we'd start off with a couple of brief presentations. Both Patrick Patterson, who was with Marco, as well as in his day job, he's with Blue Water Recovery Outreach Center. And then we also have Brandon Houle, who is with the Michigan Department of Health and Human Services today, who handles harm reduction internally, are really going to help us define that lived experience. So Brandon, Patrick, why don't you take it away in your presentation? Patrick, I think you're muted there.
Thank you so much, Scott. My name is Patrick Patterson. I'm the Executive Director of the Blue Water Recovery and Outreach Center and serve as an individual in long-term recovery, and currently also serve as the Vice Chair of the OAC and Marco, the Michigan Association of Recovery Community Organizations. What is lived experience? It is someone who has been through the experience of addiction and knows the complexities of dealing with it and the real-life solutions to dealing with it. People with lived experience have been there themselves. They speak the client's language and they can relate to their feelings. They are considered to be their peers and play an important role in creating safe, welcoming, and non-judgmental services that successfully engage the people in their journey. And we consider solving the opioid issues and solutions by having meaningful lived experience in the room with representation of its population. Brandon?
Yeah, thanks, Patrick. Brandon Houle, currently the technical advisor on the opioid settlements with the Michigan Department of Health and Human Services. I'm formerly harm reduction analyst for the last 4 years here with MDHHS. And also a person in long-term recovery, identify as a person with lived experience. Yeah, and just to add on to how Patrick defined lived experience, I wanted to talk about the diversity of lived experiences. There's a huge diversity. Lived experience is not like a single path. It's a broad definition. There's a lot of things that can affect somebody's personal experience with substances, and those can be their just the individual factors of being human. Somebody's family, their housing situation, their education, their employment. But then when we talk about somebody's substance use, how long have they been using substances? What substances have they been using? Were they incarcerated during their substance use? How do race and ethnicity play into it? Even what was the route of administration of their substances can affect their experience hugely. Did they snort the substance? Did they smoke it? Did they inject it? So there's a huge diversity in lived experience. But one of the important things to realize is with this huge diversity in lived experience, a lot of times the options for services are very limited or cater to a really select experience. So it's really important to understand that about lived experience, and also important to understand when somebody is in the room to represent lived experience, they're representing their personal experience, and no two people with substance use experience have experienced it the same way. So the really important thing is to be inclusive and to understand that the person with lived experience is representing their lived experiences, and to keep an open mind and keep the door open for other experience. There's also when we talk about diversity and lived experience, there's a nuance that really needs to be understood, and that's the lived experience with substance use disorder versus the just lived experience with substance use. Somebody's experience there can vary greatly. So they may have some of the same needs, but the experience varies greatly. And I guess a better way to understand this is that, somebody who has a diagnosable substance use disorder, has been dependent on the substance, they may be aware of their needs. Their needs may be more severe, more immediate. Whereas somebody who is just using substances may not be as aware of those needs, even though those needs may be the same. And for example, we look at somebody who's using opioids, who's dependent on opioids, could be diagnosed with an opioid use disorder. Perhaps they've been incarcerated, they've experienced an overdose situation, they've experienced injuries related to injection, that have required emergency medical attention. So they may be very acutely aware of their needs for substance use. Now, there may also be people who use opioids for pain, are not going to be as aware of those needs, are not going to be as aware of their overdose risk, and especially if we go back 10 years, before everybody was talking about the opioid crisis. People using opioids for pain management were not as aware of the risks of that opioid use, but they could still be at risk for an overdose. They could still be at risk for the transfer of communicable disease. I've known cancer patients who were prescribed opioids for oral use and preferred to inject them or snort them, still using them, their own prescription, and using them for pain, but changing the route of administration, which greatly changes the experience. And then, people using substances may be diagnosable with a substance use disorder, but may not identify as having a substance use disorder. They're not going to seek out services because they don't identify as having a substance use disorder. So it's also important to understand that there's a lot of nuances, and somebody who has lived experience may not have lived experience with addiction. They may not have been to a treatment center. They may not have been incarcerated for their substance use. They may not have had any legal involvement. So it's important to understand the diversity there too. And when we talk about lived experience in the opioid space, both those perspectives are really, really important. And it occurs on a spectrum too. It's not a binary use substances versus have a substance use disorder, because people move through their substance use in different ways. Some people experiment, then they use recreationally, and then it's a really straight line. They move into addiction. Some people use substances, they experience issues with their substance use disorder, they back off, they change substances, they adjust courses. So everybody has a really unique experience, and where somebody's at with their substance use, it really occurs on a spectrum. And then, also in the diversity of substance use experience, we talk about the experience of people who have used substances versus the community members who've been affected by their substance use. So family members, obviously, a lot of times are going to be the most strongly affected. Somebody like Nancy in the video who's lost a child. And so their experience is really important. Nancy's, and I know Nancy personally, Nancy's experience with her family member, with her daughter, has really shaped how she helps her community, how she delivers the services her organization delivers. And so that lived experience is really valuable. And, we've also got other community members. We've got, we don't think of it a lot of times, but law enforcement, their experience with substance use. And one of the things I realized in my own use is that police are human. They're seeing the people who are being hurt by substance use and the associated policies that we have for substance use. They're seeing these people hurt, they're seeing them suffer, and they're seeing this day after day after day. And all the only tools that they've had in their belt for years is to be able to take this person to jail. So, you know, law enforcement have had lived experience with community members using substances. Employers have had experiences with their employees using substances. All these experiences are really valuable, and really can help to understand the broader impacts of opioids on a community, and the broader how remediation can be applied to at the community level. But really, if we want to see a meaningful impact in the opioid or in the substance use space, we have to listen to the people who are using the substances. That's the only way we're going to have a meaningful impact, is to help those that are using substances, and we have to have their perspective in order to be able to help them. So for the purposes of today's session, lived experience, we are referring to individuals who have personal lived experience with substance use.
Great. Thank you for that, Brandon, and Patrick as well for kicking us off with that definition. I'd like to pivot now to our other two panelists to address the question of the importance of representation. So with us today, two individuals. First, I'd like to introduce Andrew Coleman, who is with Access. He also works with the Michigan Overdose Prevention Council, and Tara King, who was with the Opioid Advisory Committee. So Tara and Andrew, talk a little bit with us about the importance of representation.
Thank you, Scott. My name is Andrew Coleman. I am a clinical social worker and clinical alcohol and drug counselor by training. And I also currently work for Access, the Arab Community Center for Economic and Social Services here in Southeast Michigan. And I oversee just multiple healthcare programs, but mostly related to harm reduction and syringe service work. And, you know, for me, just for the sake of this presentation and this conversation, I am an individual with lived experience. I do still formally have a diagnosis of opioid use disorder in sustained remission in multiple medical charts. Although I don't necessarily identify as a person in recovery, I still, you know, for me, substance use has still been a part of my life on and off, even since I moved away from the more chaotic opioid use in my late teens and early 20s. But, you know, the importance of representation in my experience is, like with anything else, you know, stigma dies in the light. There's a belief, you know, we have, you know, as I see on this, like Zoom call, see 44 participants, there's a belief that, you know, it won't happen to me. It won't happen to my family. I don't know anybody who uses drugs. I don't know anybody who has a use disorder. And the reality is we do. Everybody. I mean, you are actively, you know, in a presentation with people who are open to their lived experience and open to sharing their diagnoses of use disorders. But there are so many other people who we interact with every single day who are either engaging in drug use. And I don't mean like caffeine and nicotine and alcohol and cannabis, you know, legal substances, but engaging in illicit substances, or engaging in, you know, Brandon talked about prescribed medication that then is kind of diverted and used in ways that the doctor didn't write on the script, that you can, you know, crush up your Percocet and you know, use it intranasally, but still using prescribed medications in an unprescribed way. So I think when we, in my experience, when we allow people to be open about their substance use and about their lived experience with substance use, it takes away the kind of the boogeyman of it all, right? This concept that people are dangerous when they use drugs, or people are unpredictable when they use drugs, or people can't be trusted, right? and unfortunately the recovery community has had that concept of, you know, people are self-centered in their drug use and maybe not understanding kind of the complex nature of drug use. But when we invite people to the table with lived experience, we all learn. Like we all learn that oh, this person is a mom, this person is my coworker, this person is a friend, and it changes maybe how we want to implement some of our policies or how we want to implement some of our program. And it allows us to understand, I think, in a deeper context, that if I create a policy that is going to restrict someone from receiving something, how is that going to affect my coworker? How is that going to affect my mom? How is that going to affect, you know, my neighbor? So having people with that lived experience at the table allows us to, you know, create a world where everybody feels heard and everybody ultimately gets help and gets a solution to a problem that every single one of us, and in this meeting, all of us are really in tune with it because we're a part of this meeting, but in society, every single one of us are affected by drug use, right? There's not a single person that I don't think doesn't have experience with someone who has used drugs or has experienced an overdose or has just heard about it, right? We see it all the time consistently within society. So having those people in these spaces allows us to provide, I think, better alternatives and better options for what we want to do to solve this problem.
Thank you so much, Andrew. And hello, everyone. My name is Tara King. I'm the program coordinator with the Opioid Advisory Commission. Privileged personally to be included in this call and honored to really speak alongside my co-presenters and colleagues in this space because it's such an important topic. And my role today will be slightly different than my other co-presenters because I'm really speaking on behalf of the Opioid Advisory Commission. And I know Patrick Patterson referenced his participation in the OAC earlier, but I just wanted to say thank you. Patrick is the vice chair of the Opioid Advisory Commission under the Legislative Council. So we appreciate his membership, and I'm privileged to join him on this call as well. When it comes to representation, and Andrew did such a really exceptional job explaining it, I think some of the broader considerations we look at are really intentional decisions in inclusion and representation in any space. So I know the majority of the individuals on today's call represent either local government or providers at the community or local level. And there are so many opportunities for you all to have very intentional decisions made in how individuals with lived experience are represented in your work, in education, in planning efforts, and in program development. And so I really want to speak to kind of two main themes with the importance of representation. One is really the very practical necessity for including individuals with lived experience to really develop the best possible intervention support informed by experiential and cultural knowledge. And the other is really an ethical responsibility in that any programs, interventions, supports, initiatives, anything that's developed that's really intended for utilization by individuals that have been directly impacted, are currently directly impacted, is really best informed and supported by voices and experiences of those with lived experience. And so, again, really speaking to the practical need for having informed programming and making intentional choices to engage, whether it's through communication, whether it's a learning process and just better understanding the humanity of someone's experience, which some of my other co-presenters talked really well about, but understanding that this is a ubiquitous issue. I don't think there's a person that's on this call today that doesn't have a family member, friend, or associate that in some way, shape, or form has been impacted. And so understanding that it is near universal and that there's an opportunity for all of us in our different and respective roles to be intentional and support inclusion and representation is really what moves things forward in creating impactful programming and elevating voices with lived experience. So thank you.
Great. Thank you for that, Tara. And thank you, Andrew, for sharing your thoughts. We're going to open it up to our panel. I have a few questions I'd like to kick it off with, but certainly for any of our participants, if you have questions, please put them in the chat box. We're going to be monitoring that chat box throughout, and we'll make sure to get those questions to either the entire panel, or if you have questions specifically for any of our panelists, certainly add those in, and we'll make sure to get them addressed. Let me start with a question. Whenever we venture into this area that I always think is helpful, there were some terms and I think providing some definitions for some terms, some of which were used during each of your presentations, or some that we just throw out in general. And so I think having some common verbiage and definitions of some terminology is helpful. So a few words, Patrick, if you could talk a little bit about the definitions and terminology regarding prevention and RCO. Brandon, if you could talk a little bit more about when we say harm reduction or we say recovery. Andrew, SSP and co-occurring disorders. And then Tara, if you could do equity and community connections and safety. We'll do it in a round robin. So Patrick, take it away.
Sure. Thank you again, Scott. As it refers to RCO, Recovery Community Organization, this is sort of like looking at the new frontier of recovery over the next 5 years. Where are we going to be and what have we done? What are the different things that we've initiated in our state over the last 5 years? One of the biggest things is the RCO movement, Recovery Community Organizations. And these are really organizations led and driven by those in recovery. So they're based of people with lived experience. They're grassroots organizations that serve as critical access points for those that are seeking recovery or those that are getting out of treatment, and where is my continuum of care exist. So they really serve as great community navigators because they're central locations that may offer a combination of things that serve a lot of times in the last several years is where are our gaps in the recovery, treatment, prevention space. RCOs have really filled that role and found the niche inside those gaps to say they're going to offer the combination of being a navigator, support groups, recovery support services such as recovery coaching, hosting events or transportation, a lot of these things that create sort of this camaraderie of space, which is very important for somebody who struggled with addiction, because when I peel back the layer of the onion, addiction is a disease of isolation. So when I get outside of that point, I find myself near an RCO. And the RCO is sort of the counterweight to self-isolation and self-pity. They're always motivating, they're encouraging, they're energizing. So finding the nearest RCO, they're also very underfunded. So as a result, as it relates to opioid settlement dollars, RCOs are well utilized and well underfunded. So it's definitely something to take a look at as we venture into the next year, 2 to 3 years and beyond. As it relates to prevention, what is prevention and why is it important to understand it? Preventative measures are, I get out of treatment and I venture into my next couple of years in recovery. How do I prevent myself from using again? Those things have to do with maybe going back to an important family environment or changing my family environment, understanding my behaviors or understanding my feelings and how I get aggravated and what are some coping mechanisms that I have to do and so I don't go out and use again. But putting myself in a social environment that's healthy, friendly, understanding the barriers that I might have in order to get those surroundings around me, so that the more I understand, I start to build this preventative and recovery capital. And those are very important things to understand in my own journey, because as I have higher recovery capital, I have higher probability of success in recovery, meaning let's say I just went to treatment for 30 days and I go back and I go to my old environment again, that was self-destructive. When I don't know where to go for support groups, when I don't know where to go for transportation because I got my second DUI, when I don't know where to go to for somebody to speak to, support groups, events, friendly, healthy environments, that's low recovery capital. But when I surround myself with healthy friends, a healthy softball team, a healthy organization that has all of these sort of things, these are preventative measures, and it's also building my recovery capital. When I have high recovery capital, I have high probability of success. I'm gonna pass the torch on to Brandon.
Yeah, Brandon, jump in.
Sure. Yeah. Take it away. Always like following up with Patrick. Thank you. So yeah, defining recovery, right? So you sure threw me a doozy with this one, Scott. Very subjective definition. If we asked all of our presenters on this call what their definition of recovery was, everybody would be different. If we asked the thousands of people in Michigan that are in recovery what their definition of recovery is, you would probably get no two answers would be the same. And so, I'll just give a few definitions here. And one that I really appreciated was from William White, a great writer on addiction and recovery. When he was asked to define recovery, he did not stop at one sentence. It went on for pages and pages, but his first line was, addiction recovery is far more than the removal of drugs from an otherwise unchanged life. So for some people, recovery may be, just the removal of drugs from their life. It's often not the way that it works. So we look at the SAMHSA definition, a process of change through which individuals improve their health and wellness, live a self-directed life, and strive to reach their full potential. We're not even mentioning substances in that definition. Merriam-Webster, the act, process, or an instance of recovering. 2, the process of combating a disorder such as alcoholism or a real or perceived problem. So, there's no concise definition of recovery. It's the way I've seen it, throughout my time in recovery and in substance use is that, everybody really has their own definition. And the definition that I like best is from the Chicago Recovery Alliance. And that's any positive change. And that's as the person sees it for themselves. I'm the only one that can define what recovery looks like for me. And that has changed a lot throughout my recovery, identifying as being a person in recovery. At the beginning of my recovery, all I wanted was to stop using opioids. I wanted to stop going to jail for using opioids. I wanted to reduce my overdose risk. I didn't want to use opioids anymore. I still wanted to be able to drink when I wanted to use other substances. I wanted to be able to, opioids were keeping me from maintaining employment. So that was my goal. I wanted to stop using opioids so that I could get a job and I could stay employed. I didn't really have any plans to do anything else. And with that goal in mind, like I was pretty happy right there. Later on, years later, I decided that I wanted to remove other substances from my life, make other changes to my life. But it varies greatly for everybody. And throughout their recovery, their definition may change, their wants may change. So I like to stick, sorry, long answer for short question. Any positive change is the way I've seen it most effectively applied. And then moving on to the definition of harm reduction. So harm reduction can be a pretty, a lot of things can fit under the term harm reduction. I mean, prevention efforts. If we're preventing primary prevention, if we prevent somebody from ever using substances, that's harm reduction, right? If we offer substance use disorder treatment, so somebody's using substances, they cease using substances, that can be harm reduction. But when we apply harm reduction to substance use, more specifically, we're typically referring to a certain set of services, which Andrew's going to talk about in a little bit, which are syringe service programs. So the definition of harm reduction from the National Harm Reduction Coalition is: harm reduction is a set of practical strategies and ideas aimed at reducing negative consequences associated with drug use. Harm reduction is also a movement for social justice built on a belief in and respect for the rights of people who use drugs. So again, a lot of things can fit under the umbrella of harm reduction, but more specifically, it's used kind of synonymously with syringe service programs here in Michigan. And so with that, I'll pass it on. Thanks.
Thank you, Brendan. Yeah, and throughout this presentation, you might hear a acronym called SSP, which stands for Syringe Service Program. Traditionally, in the past, many of you might have heard the term Needle Exchange Program, which is a more outdated term, but essentially what an SSP is, or a needle exchange program, what they are risk reduction programs, harm reduction programs designed to provide individuals who are engaging in drug use the necessary items so that they don't experience greater harms associated with drug use. So syringe service programs started really in the 80s in response to the HIV/AIDS epidemic that was occurring in both the United States and Europe at the time, in order to reduce HIV transmission rates among injection drug users, which I read a study a few months ago was something like 90% of injection drug users were contracting HIV in the 80s before the implementation of needle exchange programs. As well as providing the other items necessary for overdose prevention. So within the last, Brandon might be able to clarify this more, but I would say in my experience within the last probably 10, 12 years, syringe service programs became kind of avenues for naloxone distribution or Narcan distribution. They became programs to, outside of preventing hepatitis C, HIV, and soft tissues infections, they became programs to distribute overdose prevention items, including naloxone, and more recently, fentanyl test strips and xylazine testing strips, so that people reduce their risk of an overdose. We want, I think, as we always discuss, we want people to be alive, because people who die don't get care. That is not an opportunity for them anymore. So you will hear, again, just kind of in this conversation today, just that SSP. We did move away from the term needle exchange because there is still a stigma, right? When we talk about syringe distribution and providing people with clean syringes for injection drug use, or pipes, because we provide pipes for people who don't inject, or straws for people who use intranasally. We moved away from the concept of needle exchange because we're not just giving people needles. What syringe service programs do is provide a connection to an active drug use community that really any other time would not be connected to a recovery community. People who are injecting drugs are not always showing up to a clinic to see a therapist because they don't necessarily feel that that's what they need to do, or they might not feel comfortable going to a drop-in center, right? Or like an RCO, right? That might not be a space where they necessarily feel that they belong yet. So syringe service programs do a great job at keeping people connected in the community to formal healthcare programs, to formal professionals working in this field, so that when or if there is a chance or an opportunity that they want to see a change or that they want to change, that is there and they're able to kind of access directly. The other term that you might hear kind of in this presentation today is a term called co-occurring disorders. And co-occurring disorders are just having both a behavioral health disorder, a mental health disorder, and a substance use disorder at the same time. So oftentimes, I've been a therapist for 10 years or so. Pretty much anybody that I've treated that has a substance use disorder has another behavioral health disorder associated with it. So we would see people quite often, or even in my own career, I'll see people quite often, they have a diagnosis of schizophrenia and a diagnosis of alcohol use disorder because they're using alcohol to kind of stop those hallucinations from their schizophrenia. Or very common, we see this very commonly in the substance use disorder community, high rates of trauma, right? If you talk to people who are in recovery or have lived experience. Oftentimes they will talk to you about trauma that they experienced in childhood or trauma that they experienced in active drug use. So we will see people who have, opioid use disorder and post-traumatic stress disorder. It is a bit of it's a bit of like a chicken and the egg situation, right? Which one came first? Did the substance use disorder create the behavioral health disorder, right? Did the massive amounts of methamphetamine that you're using create psychosis? Or did your trauma become the thing that caused your substance use disorder because you really didn't know how to manage it without the use of a substance? So throughout this presentation, you'll hear kind of both SSP thrown around, which is just a store and service program, and then the term co-occurrent disorder, which again is just two disorders being managed at the same time.
So I think, Scott, the terms referenced for me were equity, safety, and possibly community connection, if I remember correctly. So I will do my best to kind of define them, but in doing that, I might speak about those terms more conceptually, because I think all three of those terms are really ideas that can be embraced in practices. And so I think that might be kind of a helpful discussion, at least right now, for a few minutes to kind of understand the importance of those and ways that those concepts can be supported in active practice. When we talk about equity, I think similarly, there's 44 of us on this call. We probably will have a variety of different definitions for what that means. And so for the purpose of this discussion, I want to speak very broadly to say, really at the core of equity is recognizing unique differences and needs in individuals and communities. And so in understanding that and applying it, because we have individuals on this call from different communities geographically throughout the state, from different communities economically, socially, culturally, that at first an understanding of those unique differences is a component of equity. And then also understanding the differences in impacts within different communities is a component of equity. And so as it relates to developing supportive and responsive programming, whether it be programming for substance use disorders, programming for broader behavioral health or response efforts at the community level, really being thoughtful about how equity, the differences that may exist among communities or individuals, is being factored into an assessment of what is occurring at a community level, and really creating intentional efforts to support equitable outcomes within different communities. And so that's really the kind of the way that we'll speak about equity further in this panel discussion, and how I'd like to frame it, at least in looking at things from an equity lens and really thinking very broadly about the unique differences and needs of individuals and communities. The next concept that was discussed was safety, which I think is probably of central importance when talking about ways to not only meaningfully engage, but thoughtfully support individuals with lived experience. And part of it is creating spaces, again, intentionally, that are not only supportive, but are safe. And you've heard my fellow co-presenters talk about kind of the stigma attached to substance use disorder, and really all that is attached to those experiences. And I think at the base of any sort of practical programming, planning, development is intentionally creating safe spaces where individuals can not only be heard, but feel comfortable and safe being a part of. And so kind of a strategy to support that is, again, very simple, but sometimes very difficult, in having an authentic and meaningful commitment to caring, to having humanity and compassion for each other, having an authentic commitment to learning, to partnering, to listening, to being empathic to other experiences, of which there are myriad. and really entering into any conversations or spaces in which safety is a discussion with an open mind and open heart, and really trying to be empathic to the experiences of others. The last term or concept was community connection. And I believe Patrick talked about it earlier, but really the opposite of addiction, this idea, the opposite of addiction is human connection, more broadly, creating community. And I think whenever we're talking about meaningful inclusion, representation, supporting and elevating voices with lived experience in any setting, the ability to engage meaningfully and create a sense of community is of central importance. And so you'll hear it throughout this discussion. You'll hear it in some of the broader work happening in different spaces. But I just want to emphasize that the ability to engage and meaningfully connect, honestly connect, earnestly connect with others is a huge piece in supporting meaningful engagement with individuals with lived experience.
Thank you for that, panelists. Appreciate that. I'm going to go in reverse order this time to give Tara the first shot, followed by Andrew, and then Brandon and Patrick. But before I do, I just want to mention there was a request in the chat box whether or not this will be available afterwards. And yes, this webinar is going to be available on the MAC website. We'll be getting that out to everyone, as well as our respective groups will certainly be driving people to watch this webinar afterwards as well. Aaron, if you could put the link in the chat for everyone. There was a request if they could get that video that we showed, the personal experience one, if you could just put that in the chat box for everyone, and we'll get that out to all the participants. My next question, and Tara, as I mentioned, I'm going to start with you. It's a pretty broad question. Talk about why it's so critical to engage people with lived experience in all facets of the work, from planning to implementation. Talk a little bit as well for the panel. Each of you probably have a chance to talk about certain segments, but talk about the importance of engaging organizations within that work, and then how do you really utilize the voice of those individuals in the work? How can they be engaged best?
Thanks, Scott. Big question. Like you said, very broad. I think I'm going to start by just talking about things from a value-based perspective. So regardless of what type of work you do, I imagine many of the individuals that are attending today have kind of a variety of sectors and organizations they may represent, from local government to different provider community service-based organizations. And so I think to kind of start it off, it really is a self-reflection or an organizational sort of introspection around what your values are, right? If you value prioritizing individuals with lived experience, if you value experiential knowledge, if you value equity, if you value cultural knowledge, if you value an informed perspective to doing planning specific within that setting, if you value elevating voices that have been impacted, if you value an ethical responsibility to doing that, then I think engaging individuals with lived experience is going to be a priority, right? And so part of it is figuring out, well, what is your value set, and how do those values apply to what you're doing as an organization or as an individual? The necessity, and I'll again speak practically, there's a necessity to engage individuals with lived experience, organizations that are supportive of individuals with lived experience, quite practically, because it is the best way to inform an understanding of what to do and how best to do it. And I think if there's a value to doing that work and having an ongoing commitment to learning, to revising, growing, partnering, building relationships, and really incorporating the different experiences and perspectives that are offered from different communities, especially those with lived experience, then it's going to come again very naturally to incorporate individuals and organizations that have been directly impacted. I'm going to tie it over just for a moment, I think probably to some of the work of the Opioid Advisory Commission, because this is a key piece of what our commission does and kind of one of the key principles that we really are trying to emphasize. And, you know, it's not the sole task or responsibility of the commission, but our commission makes recommendations to the state legislature and other state leaders, primarily for the purpose of funding and policy. And so there's a broader topic at play right now with opioid settlement funds. And I use this as an example because from the perspective of the commission, given the nature of these funds, there is an ethical responsibility to include voices with lived experience, those that have been impacted. And beyond that, that's kind of the top point. The second layer to it is we want to have an informed perspective, not only from those that may have lived experience historically in their past, but also those that are in active use, which would also be in lived experience, individuals at any point along the continuum, as well as family members impacted, because it provides the best possible understanding of the issue, of potential solutions to address the issue, and an opportunity to recognize where things need to be fixed if they're not going the way that they're intended. So again, I'm kind of using a practical example with this, but I think regardless of the setting, the sector, the organization that you're a part of, if there's a commitment through those values to doing the work and doing it honestly, and including community voices in that, this will be an essential component to any activity that's done.
Andrew, go ahead, jump in. Thanks for that, Tara.
Yeah, thank you. Yeah, thank you, Tara. You know, for me, actually, this is like really anecdotal for me. For any of you who have like known me personally or have ever talked to me before, you know, I'm not from the state of Michigan. I moved to Michigan in 2020 from the great state of New Jersey, where Bruce Springsteen is king. And I took a job, you know, when I moved out here, I took a job at Access. There was actually, even before I moved out to Michigan, a brand new syringe service program was being opened at Access, and it was the like only one in the country. And after a year, or after about 5 years of clinical social work, especially drug court mandated clinical social work, I got kind of disenfranchised with just that cycle of people coming onto my caseload and then being incarcerated because they just, you know, they couldn't do what they needed to do, right? They have a use disorder and it's difficult. And so I always knew I wanted that job, and I, you know, sure enough, I was like, well, when I move out here, I'll apply to it. And when I moved out here, it's open, I applied to it, and I got the position, and I was like, great, I got the job. There was no one coming to this SSP here in Sterling Heights, Michigan. We had no clients, zero. And I, on my end, was not an active drug user in Michigan. I didn't know a community of drug users in Michigan. I had come from a totally different community. And very quickly, I realized the only way that I can be successful in my role of a syringe service program is to go find drug users. I need to go find drug users. I got a lot of pushback from the other healthcare organizations within the community. They didn't necessarily want an SSP around. They didn't necessarily, you know, I always got the comment, we love harm reduction. And then when I would bring up needles, they'd be like, well, we don't like that. We don't want that. We like the other part of harm reduction, not the needle part of harm reduction. So I kind of learned really quickly that the only way that I was going to be able to really grow a syringe service program and be successful in a syringe service program was to target drug users, the people who need this. And very early on, I made some connections with people who were actively using drugs, ask them, introduce me to your friends. I don't know anybody here. Just introduce me, anybody, give my number, everybody, give my number to everybody. I will talk to anybody. And kind of very quickly, within like 6 months, we went from distributing, 100 syringes a month. And then, kind of 6 months, 8 months later, 2,000, 3,000, 4,000 to up till today, like 60,000 syringes a month are being distributed through one SSP. And that was only because people with lived experience, people who were active drug users, trusted me enough and were kind enough to invite me to their space. They were open enough to say, you know what, this person, I don't know this guy, I don't understand his accent sometimes, but this person is kind enough to let me in, or to be here. And it turned out to be really successful. It turned out to be, for me, just a beautiful moment and a beautiful realization of, yet again, this is why, yet again, the drug use community is saving the drug use community. They are always the ones on the forefront of saving each other. And I would like a world where maybe they don't have to, but that's where we're at today. And because of incorporating those concepts and incorporating that understanding, we became really successsul. On another end, our SSP has always been, I talk about my own experience with drug use, but the last time I used illicit heroin was in 2010. So fentanyl was not a thing in 2010. There was no fentanyl in your drug supply. It was really hard to get fentanyl in 2010. And even still, injection drug use was not my experience too. So even within our certain service program, the drug use community were the ones that say, hey, these are the needles we like. These are the cottons we want. We want IM naloxone. We don't want intranasal Narcan. And they really advised me on how to provide the things that were going to help people the most, and not to waste my time on things that weren't going to help anybody. I saw that video. They had McKesson needles in it. I always got pushback on McKesson needles because they told me they're bird. So, they told me we only want Easy Touch or BD, and knowing and just respecting and providing them the things that they want, because otherwise they won't see you. I mean, people who are using drugs, if you don't have what you need or what they need, they're not coming to you. They're going to go find it elsewhere outside, because that's what they've always had to do. So for me, incorporating people with lived experience, incorporating and engaging with people with lived experience has really just grown this healthcare program to the point where now they're able to access so many other services just because we've been able to establish a community that trusts us, that relies on us, that we rely on, right? It's very much a symbiotic relationship.
Great. Thanks, Andrew. Brandon, followed by Patrick.
I think one of the observations, should be taken away from this panel is that, so us presenters on here, representing lived experience, we're in a place where you all are sitting here listening to our webinar. We have some influence on policy and programming. We are the minority in this space, though. In the opioid response, in the substance use response space, we are the minority, the people with the lived experience. And so it's been a lot of these programs, initiatives are created by people who don't have that experience, and they overlook things. And I guess one of the examples, and it's kind of a shame this is being recorded because I don't know if this is going to translate very well, but so we got a bunch of smart people in this room. I imagine all of us could get together and we could read a bunch of material, and we could probably design a really great parachute. Okay, I've never jumped out of a plane. Now we could design it, we could go by all the specs, we could get the best engineers on it. But I don't want to be the one that jumps out of the plane with that parachute if none of us have tested it, if none of us have used it, if we've not applied it practically. And sorry, that's not a great example, but that's what's happening. A lot of these programs are not designed for the people that they're meant to serve. They're intended to serve, and that's what I would see when I was still running a syringe service program. We had a team of recovery coaches, and I really sometimes envy Andrew's spot right now, really being on the front line there. When people are looking to make a positive change in their life, whether it's, ceasing substance use or, using a sterile syringe, he's right on the front line. And that's what I would run into. People would be coming in for syringes. They'd say, hey, I want to stop using drugs. I want to go to treatment. And I would be the first one to hear it, and I'd be able to help them. And so we ended up hiring more recovery coaches that could fill that spot as our organization grew. And one of the things we found out with the Access Center, people getting into treatment, one of the greatest needs of our people while they were waiting to get into treatment was food and cigarettes. There was so much attrition because people would be in the waiting room of the Access Center where they'd have to sit for, 3 or 4 hours to talk to the intake person. And they would leave because they would run out of cigarettes or they would get hungry. And like, are they going to make it back? Maybe. And so, we had a budget for food and cigarettes. It wasn't federal funds, I hope, because we can't buy tobacco with that. But I mean, just recognizing the unique needs of that population, how many people ended up getting that treatment, entered recovery, just because they didn't get up and walk out of that waiting room, which was designed not with that population in mind, not with somebody in mind who struggles for food, who uses nicotine, is addicted to nicotine, and so that was just another example I could give, and that was something I saw, and just the value of having people who have that experience and who are going to see those gaps and who are going to know where those points of attrition are and who are going to know where, where programs aren't designed to serve them, is incredibly valuable, because you can design a perfect program, you can design this perfect parachute, and if nobody uses it, it's not perfect. If there's holes in it, it's not going to work. So that's all I've got to add to that, and excited to hear what Patrick's got to say.
Well, thank you, Brandon. I will dovetail off of some of the similar mindset that you're going with. I mean, if I'm going to bring together and solve a transportation issue, I'm going to bring the drivers in the room, and I'm going to bring in everybody that was associated with it, not just the leadership. When I bring in just the leadership, I'm not getting the perspective that I need. And I think that's where we're seeing some of this on municipality levels or across the state is meaningful lived experience in the room. If I have a panel, a subcommittee that's made up of some sort of advisory council, where am I going to get the best perspective on some of the needs that this community has? And that's pulling together those with lived experience. And sometimes we may not want to acknowledge some of the gaps that do exist, because they do exist. And these gaps aren't small gaps either. Sometimes these gaps are the size of Texas, and we're afraid to acknowledge that has been transpiring. But if we were just to listen to those with lived experience for a minute and ask them if they could wave their magic wand, what would they do in order to, or what would they have, or some of the needs that they would have, we would have a lot of these solutions already up and running. And that's all we're asking for, is in the softest way possible. It's just to be considered to have those with lived experience in the room when making those decisions.
Thanks for that, Patrick. I'm looking at time, and we're moving pretty quickly here. So I got 2 questions. I'm gonna split our panel into 2 groups here. I'd like to have Tara and Andrew answer this one. Try to take a minute or so each. What do you see are the greatest barriers to engaging people with lived experience?
I'll start with this one. So substance use disorders, with the exception of HIV, are still the only medical conditions that are criminalized in the United States of America. We don't criminalize diabetes. We don't criminalize, well, sometimes we criminalize pregnancy. We don't criminalize you know, we don't criminalize schizophrenia anymore. We don't criminalize depression or bipolar disorder anymore. And when we put someone's entire personhood, because even being under the influence is a criminal activity, right? So when we put someone's entire personhood under the lens of a criminal activity, they're not going to talk to people. Some of the stuff, you know, I mentioned earlier, I'm a clinical social worker. Some of the stuff I'm like mandated to report, right? If you tell me that you're buying drugs with your children in the car, by law, you have to report that, right? That's child endangerment. I'm not allowed to just be like, oh, that's okay, no worries. So I think that the criminalization of substance use has become the most destructive thing to the substance use community, to the drug use community. Oftentimes, drugs in and of itself aren't dangerous. It's the criminalization associated with it. We have fentanyl in our drug supply because of the criminalization of drug use. And I think long term, the best way that we could reduce some of those barriers is by reducing the criminalization. Again, Section 8 housing off the table if you have a drug charge. FOSFA loans, right? You can't. I was only able to go to grad school because I was never arrested, but if I had a criminal charge, I would have never been able to go to graduate school. I would have never gotten the loans to go to graduate school. General assistance or TANF benefits, if you have a drug charge, off the table. So reducing some of that criminalization, I think would reduce a lot of those barriers. This community doesn't trust healthcare providers. This community doesn't trust law enforcement. This community doesn't trust doctors, nurses, therapists because they are criminalized, and because of that criminalization, they are stigmatized.
Thanks, Andrew. I'm going to build on kind of the great foundation that you just put forth regarding this question. I think in looking at this as well, you know, this webinar offered today was intentional. It took people behind the scenes, Mac primarily, initiating the conversation and having an intentional effort to say, this is something needed, necessary, and the topic should be discussed. And I say that because I think one of the primary barriers is really at times the lack of education or access to understanding not only the importance in different systems, in a variety of different systems at different levels, but also the means and mechanisms to best learn and engage. And so something just like this webinar is a perfect example of taking an actionable step to kind of move in a different direction in being intentional, not only with engagement, but also in learning, right? Really having a commitment to learning about individuals that have lived experience, ways to engage, what those experiences are, and how to be a supportive partner. So I think that's one piece in terms of a barrier. The other piece that Andrew really talked about was one of trust and systemic harm, right? So individuals that have lived experience, again, we're talking about myriad of experiences that are diverse and different and you know are as unique as we are as individuals, but there are overarching experiences in which encounters and interactions with systems at different levels has not fostered trust. And so again, using sort of an intentional lens in how to improve trust building, empathy, exercising empathy, really demonstrating a meaningful commitment to partnering and having some humility from a systems perspective, whether we're a provider within that system or we're the organization itself, really having some humility and understanding that first we have to listen, recognize where there have been historic harms, where there may be barriers, and taking steps, especially by listening to those that have lived experience, in what those meaningful steps can be to move in a different direction of support.
Great, thanks for that, Tara. I'm going to ask this question just to Brandon, and then Patrick, we're going to have you kick off my last question round robin. Brandon, you talked a lot about nuances and the uniqueness of everyone, that everyone brings a different story. As I think of locals trying to engage people, we're trying to avoid what I'll call tokenism of just saying, well, we've got a person, but yet at the same time, when you talk about all those experiences, how do you strike that right balance? Knowing that we're trying to make decisions amongst a group, we want that voice, want that representation. We don't want that tokenism, but we want to be inclusive as we can. How do you do that?
Yeah, that's a good question, and really difficult process to enact, not impossible. And you're never going to get a truly representative sample. You know, it's not going to be a finite perspective either. One of the things that we can do to get the best the most rounded perspective, the most inclusive perspective is continue to sample. Not limit ourselves to, okay, we have one focus group with lived experience. Having it on a recurring basis, having multiple locations. It's also important to understand the geography, the access, time access. So, where are we engaging our folks with lived experience physically? Where's the physical location? Are we changing that? Are we trying to be as inclusive as we can? What are the hours? People have working hours. Are we including incarcerated populations? And so, yeah, we're never going to get a perfect representation, but what's important is the ongoing intentional effort to engage with the people with lived experience and to also make it an equitable space. It's also important to remember that a lot of people who may be engaging in your planning efforts may be doing so as part of their paid position. They may be, a provider, and their employer is paying them to be there, be part of this group. People with lived experience, you're trying to get their perspective. They may not be employed in the space. A lot of people who have lived experience are not included in this space right now, are not included in community planning efforts, are not, employed in that space. And so financial incentive can also be helpful. If you're expecting somebody to take time out of their day or take time off work to be involved in the process, the really equitable practice is to make sure that they're going to be compensated for their time and energy. And it's also, sharing your personal experience. You have to come from a real place of vulnerability. As Andrew said, your entire life is criminalized if you've got this lived experience. And so to share information, to give any more information on that is putting yourself in a really vulnerable spot. So it's important to, if we want to get that perspective, that inclusive perspective, do as much as we can to keep the doors open for people. And again, no effort's going to be perfect, but as long as it's intentional and ongoing, and we're listening and letting the people with the lived experience guide those efforts, and that's a great question to ask the group that you do have in the room. If you do start with a group of people with lived experience, hey, who are we missing? Where do we engage others with lived experience? And so that's really the best we can do, is to just make that ongoing effort.
Good. Thanks for that, Brandon.
Mhm.
I'm going to give everyone sort of the, if you can do this in 30 seconds, that would be great to close things out. I want to hear from each of you. What practical steps do you think local governments should take to engage this population? And Patrick, I'll kick it off with you.
I would suggest by going to local community-based organizations that have a pulse and heartbeat on what's going on in the local recovery community. And instead of us being the minority, leverage those individuals and maybe just have an open mind to say, could it even become a majority If I've got a room of 15 people, see if 7 or 8 of them can be representations of those with lived experiences that have served on the front lines or working within the community-based organization system.
Good. Brandon, how about you?
Yeah, shameless plug here. MDHHS, we do use the Michigan portion of the opioid settlement funds to fund technical assistance through the Michigan Technical Assistance Collaborative. So there's a technical assistance provider there. You can contact me to provide that. Amy Dolinky at the Michigan Association of Counties is excellent starting point for communities looking to provide technical assistance or to get technical assistance in planning and engaging with people with lived experience. So there's resources out there. You know, Tara as well, Patrick, any of us on this call, I'm just going to go ahead and volunteer, are happy to help a community engage with people with lived experience. We all care very deeply about this.
Andrew, how about you?
Yeah, I think as Patrick and Brandon are highlighting, come talk to us. Come see what this is about. Come, you know, like in terms of our certain service program, I invite people here all the time just to I especially want to invite the people who don't believe in these types of programs so that I can show them what they actually do. You know, the people who believe in these programs already know what they're doing, but yeah, come talk to us. Also, like your friends or family members, right? Again, we all know people who have lived experience who are in recovery from substance use disorders. Talk to them. Just it's not like it's like any other medical condition. I don't shy away from my dad's diabetes. I don't want my parents to shy away from my opioid use disorder, right? So yeah, I think having some of those open conversations, stigma dies in the light. So having some of those open conversations will maybe change the mindset about how we want to fix these problems.
Great. Tara, bring us home.
You know, I think this is a topic, quite candidly, that can be in some settings and has historically in some settings been politicized at all different levels. It can be politically convenient, it can be politically inconvenient. And I say that because I think the starting point in any setting, wherever you work, wherever you exist personally or professionally, is having an authentic commitment to caring. I mean, really starting with that, an authentic and honest commitment to learn if you don't know, to trying to engage, to go into it in a good way where there is an honest and authentic commitment to doing this in whatever way it looks, but starting with that at the base.
Thank you. And we'll leave that as our last word on the panel. So Tara, Brandon, Andrew, Patrick, thank you for just sharing your perspective, sharing your personal stories, but really providing and rounding out a very informative panel. I appreciate all you've had to share. As has been mentioned, there's a lot of resources that are out there. I'm going to turn it back over to Amy Dolinky at the Michigan Association of Counties to share a little bit about some of those resources. So Amy, take it away.
Thank you, and for moderating that, Scott, and thank you to the panel. This is unbelievably excited about this webinar and have a million ideas for potential future webinars after this. So just wanted to share some resources with everyone on the call today, and of course you will receive these slides as well as the recording that'll be on the MAC website. So we do have all of the entities that are presenting today, their websites provided here. But at the top, really some key resources that focus on the importance of engaging individuals with lived experience from national sources, as well as information about a local initiative here in Michigan that started in another state and has really been making its way around the country, which is the Recovery Friendly Workplace Initiative. So just another thing to really look into, to understand when we look at individuals that are currently using substances or with substance use disorder, we know that the majority are currently in the workforce. And there's a lot of policies that workplaces can enact and a lot of ways that we can see maybe different sectors coming to the table in this opioid settlement work, the business sector, and other entities as well. So something else to think through in your planning efforts. And I did want to give Tara a second to talk about some of the activities happening around the state right now that are focused on hearing from individuals with lived experiences and other community members.
Thank you, Amy. And I'll be very brief. I know we're towards the end of the webinar, but just to put it out there, the Opioid Advisory Commission has sort of an longer term initiative called the Community Voices Initiative. And one of the key pieces within that is really partnering, engaging in different communities throughout the state to hold listening sessions. Those are open to the public. We do both non-public and public. For some of our non-public sessions, those may be more tailored to different sectors or groups. For public sessions, it really just depends on the community. We've looked at different organizations, especially the recovery community organizations, community mental health authorities, community-based organizations, faith-based organizations, just depending on the community that we're in. But I say that because the aim of these listening sessions is to really try and hear from community members, all community members, but especially those that have been directly and deeply impacted by the addiction and mental health crisis, to learn about the experiences, the needs, the suggestions, the strengths, insight around how community members believe state opioid settlement dollars should be used. So I just put it out there because you may hear about community listening sessions coming to your community. Right now, we are in the PIHP Region 6, which is Washtenaw, Monroe, Lenawee, and Livingston County. So we'll be holding some sessions next week. Those are ongoing. We'll also be in Saginaw. We had previously held sessions in PIHP Region 5, but we'll be going back to Saginaw in early to mid-March for sessions. So we appreciate inclusion and participation. And if there's any questions, please don't hesitate to reach out to Amy or myself.
Thank you, Tara. And just as a reminder to folks on the call that may not know, as Brandon pointed out, there are numerous technical assistance resources available to local governments in this process. So this is just a bit of what technical assistance MAC can provide. And just wanted to provide an opportunity for folks to reach out. There is a link for technical assistance here and also my contact information. And I'm happy to get folks connected to any panelist that they have interest in connecting with as well. But again, thank you to all of the panelists and folks that were here today to be a part of this. And thank you all so much for attending this webinar on a really critical topic.
Thank you all. Take care.
Thank you, Amy.